Hello everyone, welcome to my YouTube channel. Today we are going to talk about management of DVT, part 3 of thromboembolism, VTE. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. The main goals of VTE prophylaxis are to A. Stop clot from forming or growing. B. To reduce chance of another clot developing. There are two types of prophylaxis. It can be divided into non-pharmacological or mechanical we call it, or pharmacological prophylaxis. For pharmacological prophylaxis, is contraindicated in patient who has high risk of bleeding, non-hypersensitivity to agents used in pharmacological prophylaxis, history of or current heparin-induced thrombocytopenia, and D. Creatinine clearance less than 30 ml per minute. Mechanical prophylaxis can be used as a standalone or in combination with pharmacological prophylaxis in patient who has no contraindication. For mechanical or non-pharmacological prophylaxis, I am going to cover a bit regarding A. Graduated compression stocking, B. Intermittent pneumatic compression devices, C. Inferior vena cava filters. For graduated compression stocking, as the name implies, it is a graduated compression of lower extremity. It applies pressure at ankle. It reduces pooling of blood in deep veins, which can enhance the velocity of blood outflow towards the heart. Graduated compression stocking may increase risk of falls in mobilizing patient. Patients should wear appropriate non-slip footwear. Stockings must be removed daily to assess the skin condition and perfusion and provide skin care. There are 3 different pressure levels of compression stocking. A. Moderate pressure, around 15 to 20 mm mercury. Strong pressure, around 20 to 30 mm mercury. Extra strong pressure, around 30 to 40 mm mercury. Compression stocking is contraindicated in patients with A. Morbid obesity where correct fitting cannot be achieved. B. Inflammatory condition of lower legs are present. C. Severe peripheral arterial disease. D. Diabetic neuropathy whereby there is an increased risk of injury due to reduced sensation. E. Severe edema of legs. F. Unusual leg deformity. G. Allergy to stocking material. And H. Cardiac failure. Recommended graduated elastic compression stockings with pressure of 30 to 40 mm mercury at ankle for 2 years after DVT to prevent post-phlebitic syndrome. B. For intermittent pneumatic compression devices, its function is by cyclic inflation and deflation that promote venous return and increase fibrinolytic activity. Intermittent inflated with air to a 30 to 55 mm mercury pressure in a uniform or sequential fashion. Is around 10 to 35 seconds. This followed by 1 minute of deflation period to allow the leg or foot to refill with blood. C. Inferior vena cava filters. It is inserted through the infrarenal, jugular, femoral, or antecubital veins. It aims to relieve pulmonary vascular obstruction in patients with proximal deep vein thrombosis. Indication for vena cava filter in patient who require surgery in recent thromboembolic event. Relative indication is in critically ill polytrauma patient. Pharmacological indication is in A. Preventing VTE events in major orthopedic or lower limb surgery. B. Venous thrombosis treatment. C. In coronary artery events, example in patient who has unstable angina, non-ST elevation of myocardial infarction, or STEMI. Example of pharmacological agents that are going to be covered are A. Unfractionated heparin, B. Low molecular weight heparin, LMWH, C. Warfarin, D. Oral direct thrombin inhibitor, E. Fondaparinaux. For A. Heparin, it is a long-chain pentasaccharide. It inhibits factor 1, 9, 7, and 2. We can monitor via APTT. We need to be adjusted based on weight, and APTT of 1.5 to 2.3 times control is desirable. Reversal use are protamine sulfate. The risk is heparin-induced thrombocytopenia and bleeding. Heparin can be stopped after 4 to 5 days of combined therapy with warfarin if the international normalized ratio INR of prothrombin clotting time exceeds 2.0. B. Low molecular weight heparin, example Clexane. It inhibits clotting of antithrombin 3, factor 2A activated form, and factor 10A inactivated form. Subcutaneously administered low molecular weight heparin is at least as effective as unfractionated heparin given in a continuous infusion. The advantage of low molecular weight heparin are: it has longer biologic half-life, it can be administered subcutaneously once or twice daily, dosing is fixed, laboratory monitoring is not required, risk of thrombocytopenia is less likely, it can be discontinued 12 hours prior to operation. Low molecular weight heparin are the treatment of choice for pregnant lady with acute venous thromboembolism because the low molecular weight heparin do not cross the placenta. Based on ACCP guidelines, weight-adjusted therapeutic dose of low molecular weight heparin should be used for the treatment of VTE during pregnancy and continued for at least 6 weeks following delivery for a minimum of 3 months of therapy. C. Warfarin. It inhibits synthesis of vitamin K-dependent clotting factor that are synthesized in the liver. No effect in the circulation. A standard warfarin protocol includes starting treatment at 5 mg per day and titrating the dosage every 3 to 7 days to achieve INR between 2 and 3. Warfarin need to be combined with heparin before it achieves its therapeutic effect. Reversal of warfarin are oral or parenteral vitamin K. Vitamin K antagonists should not be given to pregnant lady because they cross the placenta and the intake of vitamin K antagonist is associated with embryopathy. That means it's teratogenic, especially in the first trimester. D. Oral direct thrombin inhibitor. Example is dabigatran or Pradaxa. It is a direct thrombin inhibitor. It is reversible and it does not need monitoring. Initial treatment is started with a low molecular weight heparin at a therapeutic dose for 5 to 7 days, followed by dabigatran 150 mg twice daily for 3 months. E. Fondaparinaux or Arextra. It is a synthetic pentasaccharide. It is a synthetic analog of heparin and low molecular weight heparin. It blocks activated factor 10A via antithrombin action. The half-life is around 17 to 21 hours. It is administered once daily. It reached a peak of plasma concentration within 2 hours. Need to be avoided in patients who has renal failure. Okay, that's all for today. Till we meet again next time. See you. Bye.